Hello everyone, part 3 of our skin lecture in pathophysiology. Professor Land here. So just finishing up where we left off in part 2, seborrheic dermatitis is dandruff. In children it's cradle cap. The etiology is usually genetic or unknown. The person usually inherits it from a family member. And the clinical manifestations, as we can see in the previous slide, is they've got the scales, flakes, and on their scalp, and it can be on any place that has hair, like a beard and things like that. And those flakes will show up on the clothing, the dandruff commercials and stuff like that. So, all right, so moving on. And this is actually ringworm, or we call this Tinea fasciae. So you say Tinea for the Latin name for this fungus. It's a fungus. So we've got bacteria, viruses, fungi, insects. So this is a fungus, and we say Tinea, and then the Latin for wherever the body part. This is Tinea fasciae. If it were on the chest, the abdomen, the back, the arms or legs, that would be Tinea corpus. If it were on the hands, it would be Tinea malis. If it were on the toes, Tinea pedis. So there's other Teneas in the book, but those are the Teneas I need you to know, and that means it's a fungus. So ringworm, it's spread by contact, being touching, animals that have it. The dirt might have it as well. And the clinical manifestations, as you can see, they have this central clearing and peripheral scarring, or such as a ring. So it's a ring, and you can see the central clearing, and it almost looks like it's been scalded, like when cows are branded. So it's like it's scalding, okay? And when I was little, my sister had ringworm, and I was like, is that the ring in there? Is that the worm in there? And I didn't understand that it was a fungus. I think I was like 4 years old. But anyways, okay. So this is ringworm in a dark-skinned person. You can see, you don't really see the central clearing, but you can see the raised area of the scaling and scalding. And on light-skinned people, it's going to be more erythema, redness. So the next one, this is actually a form of contact dermatitis from poison ivy. So we have erythema, macules, papules, vesicles, pustules, and you can see a linear fashion to this because the person's been exposed to poison ivy, poison oak, poison sumac, and the etiology is just exposure to these poisonous plants. And usually when they walk by them or scrape by them with their hand or whatever, their leg, they have this linear fashions as they walk by. Gardeners who maybe don't know that they're digging into poison ivy or something can get this as well. Hikers, campers, things like that. And so the etiology is contact with a poisonous plant. And the pathogenesis is just the fact that it's poisonous, and it's an itis. It inflames the skin. That's as far as we're going to go. So contact rus dermatitis is a form of dermatitis from the poisonous plant. I got poison ivy here, but there's poison oak and poison sumac. Pruritus, that's our word for itching, followed by erythema, vesicle formation, and sometimes in a linear fashion, and then it'll crust over into the secondary lesion. Sometimes you'll see pustules as well, maybe papules, but I wouldn't say papules. I'm going to take that back. It's going to be vesicles because it's going to be fluid filled. And then the next one is, this is actually impetigo, and you can see it starting to crust over here. Impetigo is a bacteria, and it is a bacteria of either Staphylococcus or Streptococcus. And usually there's vesicle formation, and then there's crusting over. It looks like the vesicles have opened up, and now they're crusting over. The thing is you see this honey-colored oozing that you don't see with herpes simplex. So herpes and impetigo can be mistaken for each other. So if the dermatologist doesn't know what it is, they might culture it. Because if you put antibiotics on herpes, it's not going to work. If you put antivirals on impetigo, it's not going to work because impetigo is a bacteria. It needs antibacterial cream. Herpes simplex virus and herpes zoster is a virus, and it needs antivirals. So you need different medications. So this is a picture of a lighter skinned person, and you can see it's all crusted over. So it's going to have vesicles and pustules that will crust over, but they have this honey-colored oozing or drainage, this honey-colored drainage. And so again, impetigo, some people say it differently, caused by staphylococci or streptococci, which is a bacteria. And it's contact, and a lot of times children get it because they touch each other, they touch toys that other children have touched, and they touch their face and their nose, and it can colonize in the nose. And a lot of times you'll see it around the nose and the upper lip. It can be anywhere on the skin, though, but a common place is the nose, around the nose and the lip. All right. So this is actually psoriasis, and I was talking earlier about the lesion of a lysification, where we have that growth of extra skin. So psoriasis can transform from this plaque-like lysification that's a papule, macule, or erythema, right? And you can't scrape this off. I mean, if you were, it would be very painful and it would bleed. This is an inherited disorder. It's a form of possibly an autoimmune disease. It's genetic. It gets passed on to children. It's a chronic skin disease, and just as a side note, these people can get arthritis if you've seen these ads for psoriatic arthritis. Papules, plaques or lysification with overlying silvery scales. We can see this silvery scale over these. And I believe when we did the matching, you saw the kind of silvery scale over that. So this is the silvery scale, and this is psoriasis on darker skin. So it does have that erythema, macules, papules, lysification, plaques. So that's the verbiage for the description. And again, a lot of these are diagnosed with a skin biopsy and some blood work. Now here's our cancers. So this is basal cell carcinoma on the right. You can see the well-defined borders, and that's a key word there, well-defined borders. And if you guys recall, it is a form of cancer that's not, it does not spread. It doesn't spread. And you can see the well-defined borders. It can have erythema, ulcerations. It can start ulcerating. And again, if this isn't removed, it can get pretty nasty because it can go deeper into the skin. Okay, so it's removed. It doesn't spread. It's probably the best cancer to have, skin cancer to have, if someone was going to have that one. So basal cell carcinoma, note the rolled, well-defined margins, and it comes from the basal, the stratum basal layer of the skin. It's from exposure to sun, especially at an early age. So put that sunscreen on yourself and little ones, the younger children as well, to prevent this. Wear hats, clothing, etc. It's the UV light from the sun and UV light from tanning beds. So this is called what we commonly call eczema or atopic dermatitis. And dermatitis can take many forms. Atopic dermatitis, I'm going to be very clear, this is atopic dermatitis or eczema. In children, it is linked with asthma. Those who have asthma can also have eczema. Those who have eczema or atopic dermatitis can also have asthma. And it's a type of allergic reaction, and it can manifest anywhere, but it loves to manifest where we bend our elbow, where we bend our knee, like the back of the knee, the antecubital space of the elbow, arm, and the nape of the neck, where we bend our neck, or where we bend our wrists or hands. I've seen some people who had it in their behind their knuckles of their hands, and we can see maceration here. We can see papules, opened areas, crusting over. It's itchy, it's pruritic. And they usually find out, what the person is allergic to, and they avoid it. Oozing, crusting, coalescent papules. So that means the papules just come together in one big papule. always pruritic. It's itchy. Erythema, papules, and lysification can happen with atopic dermatitis as well. Of the flexor surfaces of the extremities, especially the antecubital space of the arm, popliteal areas, so that's the back of the knee, the wrist, and the nape of the neck, like I said. So atopic dermatitis is eczema. Right. So this is another matching. So we've got herpes simplex virus is also called a cold sore or a fever blister. That would be type 1, correct, technically, depending on what kind of sex they're having. Again, spreading type 1 to type 2 to type 2 to type 1 is all about, oral sex, and we talked about that earlier. Shingles is the herpes varicella virus, or what we call herpes zoster. And then ringworm is a fungus. We call it tinea wherever it is. If it's on the body, tinea corpus; on the face, tinea fasciae, etc. And then impetigo is staphylococcus or streptococcus. It's a bacteria. Atopic dermatitis is an inherited disorder, and it is eczema. And they're usually allergic to something, some kind of soaps, lotions, detergents, stuff like that, and they have to eliminate those. Warts. Now, we haven't hit warts yet, but warts are human papilloma viruses, and there's different types of papilloma virus. Now, we have warts on our hands, and then there's us ladies and gentlemen can get the sexually transmitted disease, HPV, human papilloma virus. And again, it's spread by contact, and the only thing with women is that the warts are on the cervix. So the woman can end up, that can change, because remember, warts are like hyperplasia of the mucous membranes or the skin, and then it can become dysplasia, neoplasia, cancer, right? So HPV can lead to cervical cancer in women, and of course, people performing oral sex on people who have HPV can get oral cancer from HPV. Okay. And then thrush is a yeast, which is a form of a fungus, and that thrush is called, the Latin name is Candida albicans. All right, so we have to know the Latin names and the common names. So here's another picture. Oh, we're going to do a true and false here. So let's look at this true and false. So, what happened to my true and false? Oh, there it is, sorry. So a primary lesion retains its original appearance unaffected by time or trauma. So that's true, Where a secondary lesion, the lesion is changing, it's either healing or getting worse, or it's been affected by itching and scratching. The function of a skin gland is unchanged by aging. That is false. As we age, we lose a lot of the oils in our skins. That's what the whole healthcare industry is really targeted at, collagen and moisturization and retinol and all that stuff. Increased production of melanin with age results in graying of hair. So what do you think of that? So it's actually, this one is false. It's that we lose the production of melanin, and that causes the graying of hair. So I'm lucky my mom didn't go gray till she was 60, so I have a gray hair here and there, but I haven't gone gray yet, so I'm keeping my fingers crossed. I don't have to pay for the hair, or I might just let it go gray. Anyways, the human papillomavirus can invade deep into the tissues. That's false. It goes into stratum corneum. The stratum corneum, just the top layer of the epidermis, of the skin layers. Shingles manifest along the dermatones of the infected sensory nerves. That's correct. Dermatones is the roadmap to our peripheral nerves. So it usually lays dormant in that nerve, and that's why it doesn't cross the midline, because our nervous system is right or left. So it doesn't cross the midline. It can manifest on the other side of the body, but that's a different how should I say this? It's another infection. It's not that it's spread over there. It's another infection in a different nerve. Psoriasis can affect individuals of any age. Absolutely, yes. Although acne vulgaris is not curable, available treatments can be quite effective. That's true, because teens, again, there's genetic and idiopathic etiologies for acne vulgaris, and usually it manifests in adolescence because of the increased androgenic hormones during adolescence, and it tapers down as they get older and those hormones settle, and they won't have the terrible breakouts like they had in adolescence. So there's your answer keys and the rationales for the false ones. So let's continue. This is a very visual lecture. Now, this is vitiligo, the pigmentation, the loss of pigmentation of the skin. We see it on darker skinned individuals, but it can happen on people who have that darker pigmentation, maybe olive skin, Hispanic, Italian, Mediterranean. African American, things like that, the vitiligo. So what is this? The etiology is unknown, it's idiopathic. Emotional stress, physical trauma, and sunburn can bring it on. I've seen this manifest in some nursing students, that all of a sudden they get vitiligo in nursing school. As you guys know, it is stressful. Pathogenesis is depigmented sites may have melanocytes that no longer produce melanin, or may not have any functioning melanocytes, or have very few. So that's the pathogenesis. Clinical manifestations: sudden appearance of white patches on the skin, depigmented, geez, I've got a lot of typos in here, sorry about that, depigmented macule with definite smooth borders on the face, axilla, neck, and extremities. Asymptomatic, although pruritus can occur. It can be itchy. So that's vitiligo. And then we've got this reddened area, and you can see where they marked it off with a skin marker, because your goal here is to make sure it goes down. This is actually cellulitis, so inflammation of the skin. So let's kind of see, you can see it's edematous, it's erythema. When you touch it, it's going to be warm. It's going to be warm to touch. The patient will feel pain, obviously. Cellulitis, deeper infection affecting the dermis and the subcutaneous tissues. So it's the infection of the skin. So the epidermis, dermis, and subcutaneous tissues. The etiology and pathogenesis, sorry about the typos. Group A, beta hemolytic streptococci, or S. aureus, Staph aureus, but can be caused by bacteria specific to certain activities, such as fish handling, swimming in fresh or salt water, or from animal bites or scratches. So we can see this manifest in different bacteria. Pre-existing wounds from ulcers and erosions, and tinea pedis are often portals of entry. So having a fungal infection in the toes. Now, the clinical manifestations, we've got legs are the most common sight, expanding, like we saw, swollen, tender plaque with an indefinite border, fever, erythema, heat, and edema and pain. So don't have fever because it's now gone deep into the dermis where there's blood cells in the subcutaneous space, and the blood's picking up the fact that there's inflammation there, and so it's going to send a signal to the brain to increase the body temperature to try to kill that bacteria. And impairs the lymphatic drainage as well, if you can see that. I think, yeah, impairs the lymphatic drainage. So there you go. All right, that's cellulitis. So moving on to, this is a wart. And you can see it's a raised nodule or papule. So warts are called verrucae, and the cause is direct contact. So touching, whatever, sexual contact, genital warts. Auto-inoculation, so it just, starts proliferating. It can infect one cell, and that can cause the process. Also breaks in the skin integrity. If there's little lacerations or sores on the skin, the genital area, it can be open more to getting that. Now, the pathogenesis is benign papillomas caused by the DNA containing human papillomavirus. Okay, so they've got HPV within them, and we can have clinical manifestations of dorsal surfaces of the hands, especially the periunguinal areas where they appear as small grayish white to tan flat to convex papules with a rough pebble-like surface. They can be slightly elevated, they could be flat, smooth, or tan papules. And again, these can spread, these can cause cancer if it's cervical HPV warts, and also on gentlemen as well, on people who perform oral sex as well. Men can get warts on their genitals as well. The question that always comes up, someone has warts on their hands and they masturbate. Can they spread it? The incidence of that is very low, very, very low. I looked it up to spread because it's a slightly different type of HPV. So the incidence is low to spread it from hand to genitals with either, masturbating or having different types of sex with other people using the hands. So I'll just leave it at that. And that question usually comes up. Don't we have a vaccine for this, for cervical cancer and HPV? Gardasil, there's other names for it. And we start vaccinating at around 11 years old, hopefully before the person becomes sexually active. So HPV is spread because a young person starts having sex very young with multiple people. And that's how it usually spreads. Multiple sex partners at a young age. So this is urticaria, or wheals or hives. And this can actually be from a drug reaction, like they're allergic to a certain drug, allergies to food, medications, drinks. We see this with penicillin and cephalosporin allergies, insect bites, mosquito bites, we get those hives or wheals, urticaria. Viral infections, dust mites, and exposure to pollens or chemicals. It can be an autoimmune with some, autoimmune diseases. The pathogenesis is liberation of histamines from mast cells and basophils. So if you remember the inflammatory response, those mast cells are going to trigger the release of the basophils and the histamines, and that's what causes the inflammation. And then the histamine cause hyperpermeability, so the opening up of the capillary membrane of the microvessels of the skin and surrounding tissue, allowing fluid to leak out. So the capillary bed opens up and lets the fluid leak out into the tissues, causing edema and that wheal to form. Clinical manifestation is that hive, wheal that blanches with pressure. So if you push on it, it'll turn white and then it'll turn red again. So blanching is like you do a cap refill. You push on your fingernail and it turns white, and if you have good circulation, it immediately comes back. All right, so I'm going to leave it at that. So I'm going to do another recording. Well, actually, let me see if I can finish this up. Never mind. Let's look at these dragon drops. So Candida albicans is a yeast that causes throat infection in newborns and may cause systemic infections in immunocompromised patients, so HIV, things like that. Seborrheic dermatitis presents as dandruff and cannot be cured, but it can be controlled. The most common cause of allergic contact dermatitis is a reaction to specific allergen. So a lot of people all of a sudden sometimes have that hypersensitivity type 4 reaction, which they're using Tide detergent for 10 years. And all of a sudden now they're allergic to Tide detergent and they're itchy and they've got redness where their clothes hit, and then they have to buy the Tide Free and Clear with no perfumes in it and smells and all that stuff, and they stop itching. It's sometimes a delayed reaction. Certain soaps can cause that allergic contact dermatitis. 3 types of drug reactions that result in bullous skin lesions are erythema, multiform minor Stevens-Johnson syndrome, and toxic epidermal necrolysis. So these are different types of skin lesions you might see. There we go. Okay, let's see. So an excessive scar tissue is called a keloid. Both topical and systemic steroids may be used in the management of sunburn, depending on its severity. In dark-skinned individuals, petechiae may only be visible on the oral mucosa or conjunctiva. So you're going to have to pull down the lip and look for the petechiae are little purple dots on the skin or the mucous membranes or the conjunctiva, like the pink part around the eye, and that tells us that they're bleeding. So we're not going to see that on dark skin, right? Those little purple dots. So look in the mucous membranes of the mouth and the conjunctiva around the eye. Pruritus, or the sensation of itch, is a common symptom of skin disorders ranging from mild to severe. And vitiligo is a pigmentary problem of concern to darkly pigmented people of all races. Vitiligo has been reportedly precipitated by emotional stress or physical trauma such as sunburn. All right. So we have another one. So skin lesions common among older adults. So you can look in page 1320 of your patho book. Skin tags are benign, soft, brown or flesh-colored papules commonly seen in 25% of adults. A keratosis is a horny growth of an abnormal growth of keratinocytes, kind of like horns. Sorbitic keratosis are benign, but they must be watched for changes in color, texture, or size, which may indicate malignant transformation. So these are like these little oily wart-like round lesions that can happen anywhere on the skin. Usually it likes the hairline and stuff like that. Lentigo is a well-bordered brown or black macule, usually less than 1 centimeter in diameter. Solar lentigos are tan or brown, benign spots on sun-exposed areas, so they can be like liver spots. Commonly referred to as liver spots, like I said, these lesions are considered risks for the development of skin cancer. Vascular lesions include angiomas, telangiectasias, and venous lakes. So cherry angiomas are smooth, cherry red or purple dome-shaped papules that occur in nearly all people older than 30 years of age. We get these little red veiny things. They usually are found in the trunk and aren't like the chest and are generally benign unless there's a sudden appearance of many cherry angiomas. Telangiectasias are single dilated blood vessels, capillaries or terminal arteries that appear on areas exposed to sun or harsh weather, such as cheeks or nose. So you might see these little, it looks kind of like a freckle or a mole, but it's actually a blood vessel kind of popping up. So, okay, let's see what we got here. This is the time to climb. I'm going to let you guys go through those on your own in the student paste, but if you guys have any questions about them, please reach out to me. And I believe that's it. So thank you guys for watching, and I'll see you in class, and email me if you have any questions about the skin. Come sign up on my booking page to have some tutoring. Happy to help. So you guys take care, and again, thank you. I gotta find the off switch.